understand new stuff about peripheral nerves. So without any further delay, I would like to welcome you aboard, and please, you can start.
Okay. Yeah. Thank you very much, Dr. Al-Habib. It's a pleasure to be part of this wonderful educational process. I was asked today to talk about entrapment neuropathy, surgical consideration, and I know that 45 minutes will not do any justice to the topic. However, I have chosen few points that I think may be useful from a practical point of view, and I've also will try to show some area of confusion and controversies that I usually get in forms of questions or referrals. So in general, nerves are entrapped naturally as they pass in tunnels. They naturally passes through tunnels, through or under facial edges and between muscles. Pathological changes will further narrow these passages and may produce symptoms. The process is usually slow, and the patient starts complaining with the sensory complaints initially, and as the process evolves, motor weakness will develop, which is usually incomplete, which is very important to remember. It's usually incomplete. These symptoms are usually due to nerve compression, due either a static or repetitive compression, and this is very common in cases of cubital tunnel syndrome, for example. Prolonged compression may lead to ischemia and swelling that will further exacerbate the condition. You can confidently use these as a general statements. The first one is that acute presentation in entrapment neuropathies are very unusual, very, very unusual to have a patient with acute carpal tunnel or acute cubital tunnel. You should seek another cause. Another thing is that very severe pain is usually not a picture of an entrapment, and you have also to look for another cause. Usually those patients present with incomplete motor deficit, and the presence of complete deficit again should deter you from the diagnosis of entrapment, and you should find another cause. And I advise you, and I personally image all the rare entrapments that we will talk about. Now, there are entrapments of the upper limb and of the lower limb. The commonest by far is the carpal tunnel syndrome. Cubital tunnel syndrome follows, but it's still not as common. Rarely you see posterior interosseous nerve entrapment. Thoracic outlet syndrome is a very controversial syndrome, and you should make the difference between cervical rib causing brachial plexus compression versus the idiopathic thoracic outlet syndrome. And I would not put so much weight on such a diagnosis because it's been getting more attention that it deserves. We have something called Wartenberg syndrome, where you press the superficial sensory radial nerve at the forearm. Now, pronator teres syndrome and radial tunnel syndrome are exceedingly rare, if they exist. I mean, the emphasis or the discussion going around these syndromes is probably not worthwhile, and definitely I would ask the examiners not to include them in the exams, because I have not seen one yet. Entrapments of the lower limbs, the commonest is meralgia paresthetica due to entrapment of the lateral femoral cutaneous nerve, fibular tunnel syndrome, which is entrapment of the common peroneal nerve, tarsal tunnel syndrome, entrapment of the distal tibial nerve. Again, you have the so-called piriformis syndrome. You hear this diagnosis given to so many patients. This syndrome is highly, highly controversial. And again, I have never seen one. Maybe they saw me, but I don't remember that I diagnosed one or treated one, as well as the soleal sling syndrome. And this is my personal opinion. And rarely there is a form of entrapment called anterior tarsal syndrome that involves the entrapment of the deep peroneal nerve. Let's start with the most common ones, the carpal tunnel syndrome. It's quite common and it affects 5% of the normal population. So if we have 20 attendees today, one of them will develop or already have a carpal tunnel syndrome. Now, don't forget that this is usually a bilateral disease. And the reason we say that is that when the patient presents to you with bilateral carpal tunnel syndrome, don't necessarily jump to the neck as a cause, because CTS is usually bilateral. It's very uncertain whether the dominant hand is more common than non-dominant hand, but there aren't a strong reports to support either one. The most common and the classic subjective symptom is the nocturnal paresthesia. And they tend to be painful, bad enough to disturb sleep. And just hearing such a history over the phone should make you comfortably suspect or diagnose carpal tunnel syndrome. It usually improves after changing the position of the hand, massaging the hand, or flickering the hand. Beside the hand pain, you can get pain at the wrist and forearm, and as proximal as the shoulder. And that's not unusual or very rare, but usually the neck is not involved. Now, this is the cat's hand diagram that is quite useful. I always show this because the junior doctors would be surprised to know that CTS will involve the 5 fingers. Even the ulnar side, even the ulnar supplied fingers are also involved in the CTS. So numbness of the whole hand, sparing the palm, is quite classic. And usually the volar surface and the tips of the finger. Wrist pain can also be there, and it should not deter you from the diagnosis. It's usually follow the diagnosis of CTS. Now, it is not completely unacceptable to have palmar involvement in CTS cases, although this is supplied by the palmar branch that bridges over the flexor retinaculum. But it's still, the diagnosis can still be CTS. What is not acceptable is to have numbness involving only the ulnar side. Now, patients usually don't present with atrophy. However, when in a long-standing cases, the atrophy should only include the radial aspect of the hand, where the abductor pollicis brevis is. The rest of the thinner muscles are the flexor pollicis brevis and the opponens pollicis. And both of these muscles have a dual supply from the median and the ulnar. The only median exclusively supplied muscle is the abductor pollicis brevis. And that's why the atrophy in CTS usually involves only the abductor pollicis brevis. The seeing or having all the thinner muscle paralysis should always direct you to a more proximal lesion, usually C8 and T1, median cord, lower trunk, or a proximal median nerve. And of course, if you have both ulnar and median neuropathy, usually the problem is at the level of the trunk or at C8. It's been tradition to mention Tinel sign and Fallon sign in the diagnosis of CTS. And frequent and repeated studies have shown that both tests lack sensitivity and specificity. However, combining both tests will improve your sensitivity and specificity. What's interesting, and which I agree with over the years, is the flicker sign. And that was reported by Price Phillips from Newfoundland, and I know him personally. He's one of the smartest neurologists I've ever known, who showed that the flicker sign has a higher sensitivity and specificity compared to the rest of the signs. Although this is a single study that, as far as I know, has not been reproduced in a scientific fashion, but I've seen this sign mentioned in many reports and books by many experts. And as I mentioned here, when you combine Tinel and Fallon sign, your sensitivity and specificity improves. The differential diagnosis of CTS is actually not very difficult when you hear the classic story. And there aren't much in the differential. One of the neurosurgical differentials that we need to sort out is the cervical radiculopathy. And it's usually C7. It's usually C7, not C6. I know that there is lots of confusion because the famous Forestier map shows that the index and the middle fingers are C6 and C7, but other less famous maps, which actually more accurate as far as I'm concerned, is the Keegan map, which shows that the index and the middle finger are usually C7. Not only that, we know also anatomically that the sensory fibers comes from C7 through the anterior division of the middle trunk to the lateral division of the median nerve that joins the medial division and forms the median nerve. So these sensory fibers travels from C6 to the median nerve. Now, examining the abductor pollicis brevis, which is practically the only muscle I do examine in suspected CTS patients, can be a bit tricky, but the easiest way I find is to hold the thumb and ask the patient to direct his thumb to the contralateral shoulder. So if I'm examining the left hand, I'll ask the patient to direct his thumb toward the right, to his right shoulder, and basically I apply resistance and check the muscle grade or the power grade. Now, be very cautious in CTS when pain is the only symptom. Remember that numbness has a much better value in localization than pain. And when pain is the only symptom, make sure that you are not missing a different etiology or another etiology. And also, if weakness is the predominant symptom, also be careful that you are not missing a more proximal lesion or a generalized disease, namely or particularly motor neuron or ALS, which is, I remember at least 4 cases that we were able to diagnose from a patients who presented as a CTS cases. Now, remember also in older patients with long-standing CTS, their main presentation may be weakness, but that is not very common. We have so many in the differential diagnosis, and surprisingly, I had a couple patients who tells you that they feel or they can see or can feel a swelling in their proximal at their wrist, and sure enough, the MRI was able to pick up a very rare tumor, but this is very unusual. Now, EMG and nerve conduction study remains the gold standard. Remains the gold standard in the diagnosis, but we know that they miss mild cases. They have many false positive and negative results. I'm not worried about the false positive because we make the decision based on the clinical picture and the EMG. And you worry about the negative results. So now you have a patient with a classic picture, classic history of carpal tunnel, yet with a negative EMG. Yes, you can go on after discussing this with the patients and decompress them. However, I really don't do that, and I would love to have them both before we go for the decompression. Remember also that EMG changes remains for a long time following even successful decompression. So even after successful decompression, you'll have a positive EMG. So there is no point in cases of failed decompression to repeat the EMG because it will always be positive. It will not revert to normal for a long time, and they may never come back to normal. Do we need imaging in CTS? I have limited indications for that, and mainly the recurrent cases, particularly the ones that was done outside our institution. It tells you so much. MRI or ultrasound can tell you so many things that you want to know, but you need to know what you are looking for. So it's important to have the list of the causes of recurrence, which we can go over if we have time, and to make sure that you read your images or your MRI with your radiologist and try to rule out or to rule in the different causes. Of course, pediatric age group, because CTS is very uncommon in this age group. I remember just one case of mucopolysaccharidosis that we had to do. And of course, if there is a generalized disease that can cause tumors or tenosynovitis and complicated hand situations, MRI or ultrasound in experienced hand may be useful or helpful. Conservative treatment in mild cases will work and may work. In moderate cases, particularly the conditions or the situations where in pregnant patients, it is quite satisfactory, and it will just get them through the pregnancy because we know very well they will get better after delivery. It's very important to take CTS surgery very seriously and not in a cavalier way because you will be burned, trust me. The results are not 100%. They are not even 90%. I always give my patients 85% chances of improvement. I tell them that they will have pain around the scar, around the palm. They will have pain at the base of the thumb. They will have difficulty pressing on their palm. They may have a weak grip that will get better with time, and it will take a while for them to heal. In diabetics, we have left sutures as long as 3 weeks because of poor healing. And I always at the end tell them that there is always a chance that they may get worse. So 85% will do well, not necessarily a complete recovery. 10% may remain the same, and 5% will not be happy. And I tell them that there is 1% chance of having a worse outcome, and as CRPS or complex regional pain syndrome or even causalgia may happen. So my advice to the junior colleagues is not to take this procedure lightly. The surgical procedure is straightforward if we know the anatomy. We know that the carpal tunnel is at the palm, does not extend below the Kaplan line, and does not extend proximal to the crease. This is the Kaplan line. We know that the palmar cutaneous branch runs here. The palmar cutaneous branch of ulnar nerve comes here, runs here. This is the palmar cutaneous branch of the median nerve. This is the recurrent median branch that supplies the thenar muscles. This is the median nerve, and this is the palmaris longus tendon. The incision that I prefer is a line bisecting the fourth finger, and there is a reason to do that. This location will avoid the major nerves, and not only that, it also avoids or minimizes cutting the small sensory branches that basically represent the anastomosis between the palmar and the cutaneous and both palmar branches. The decompression is usually very straightforward. You have distally to see this pad of fat. It marks the bifurcation or the division of the median nerve, and 1 centimeter distal to this fat, you will encounter the palmar arch, which is basically a big arterial arch. So once I see this, I know that we are distally adequate. Then we direct our cutting more proximally as far as the distal antebrachial fascia. From the same incision, you can do both the Guillen's and the carpal tunnel. If you encounter abnormal vasculature, make sure that you don't do much of an intra-canal manipulation. I always try to see the median nerve. I prefer to make the incision of the retinaculum above the tendons and not the median nerve, as healing will prevent the adhesions to the median nerve. And if I don't see the median nerve, make sure that it's not enclosed in an accessory layer of the flexor retinaculum. This is actually a book picture. It's not my personal one. And these are the nerves we're talking about. These are the branches from the median palmar and median ulnar palmar branches. And you can see how it's easy to cut them. If you can avoid them, it would be very good for the patient. Now, we don't recommend internal neurolysis. However, particularly in redo cases, if you see this hourglass appearance, and an external epineurotomy is probably a good thing to do. And remember that very small incisions or tiny incisions are not worthwhile, and the main objective is to decompress and give yourself a good incision to see what you are doing. And if you want to do such small incisions, you can go for endoscopic procedures. Causes of failure is usually incomplete division and wrong diagnosis. And this causes of failure are common to all entrapment neuropathy. Cubital tunnel syndrome is the second most common entrapment. It's more common in males, and usually it presents with tingling with or without pain at the little or the ring finger. Pain at the elbow is also common because the nerve supplies also the elbow joint. Patients with cubitus valgus due to previous trauma are very, very at high risk of developing irritation and a cubital tunnel syndrome. One little important thing when you're examining the small muscles of the hand is to place the hand on the table, because the patients tend to use their extensors to trick you. When you ask them to abduct their fingers, as you can see, he's using his extensors, and you can only avoid this by placing their hands on the table. And this is the Fromen sign that we don't have time to show everything. Now, you can use splint in mild cases, and it works in a majority of the time, and ask the patients to avoid the habitual leaning and pressure over the elbow. Moderate cases deserves a surgical intervention. And what we do usually is a simple decompression. We have so many randomized controlled trials that show that simple decompression is superior to transposition. However, we do transposition when we fail the simple decompression, or when the patients have a preoperative subluxation or cubitus valgus, and sometimes we transpose to achieve a primary repair of the nerve. Most, or 95% of the entrapment is around the elbow, is between at the cubital tunnel and at the Osborn fascia. Very unusual to have entrapment proximally at the arcade of Struthers or within the substance of the flexor carpi ulnaris. Arcade of Struther is a very confusing arcade, but it's simply an opening in the medial intermuscular septum. It's very important to remember when we decompress, whether simple decompression or transposition, is to save these branches. And these branches are the posterior division of the medial antebrachial nerve that has an anterior division that usually is away from you, and a posterior division. And these nerves are always in front of you during the decompression. Luckily, they are deeper to the fat. They are closer to the fascia and the nerve than the fat. So you have a good space to maneuver. And so what we usually do, we do the simple decompression, then we intraoperatively, we flex the arm, and we see if the nerve jumps anterior or above the medial epicondyle. When we see such a situation, we prefer to transpose. And it's important when you transpose to make sure that you are not creating a secondary entrapment site. And after we do that, we fashion a fascial sling to keep or to prevent the nerve from returning back to its primary bed. And it's important to have a straight and a very nice course of the nerve. The results are satisfactory. However, the second surgery carry much, much worse prognosis. So it's very important not to take this procedure lightly and to do as much as you can a good job from the first case. And it shouldn't be done by a junior physicians. And you need to do this in in conjunction with an experienced neurosurgery staff. For each 100 cubital tunnel, we see one ulnar tunnel, or the Guillen's canal. And the Guillen's canal is just proximate, or just nearby the carpal tunnel. So this is the transverse carpal ligament. It extends a small fibrous band and forms the Guillen's canal. The wrong concept of releasing the Guillen's canal is that you should be releasing the volar carpal ligament and the pisohamate ligament to achieve a complete release of the deep ulnar nerve. Releasing only the superficial branch will release only the superficial branch and not the deep branch. The last common one of the upper entrapments is the posterior interosseous nerve. It's a rare entrapment, and for the sake of the time, usually those patients present with incomplete deficit and of finger drop, and the finger drop is usually incomplete, as seen in this case. So this is an engineer who's doing effectively extension of the wrist and finger on the right hand, but only doing a wrist extension and an incomplete finger extension of the left. It's very essential when you have rare entrapments, as we mentioned before, is to get an MRI, because very often you will have second pathologies, as in this case, there was a tumor of the radial nerve involving only the fascicles of the posterior interosseous nerve. So after we achieved a complete decompression, we didn't like the amount of compression that we have found, so we went back and we treated the tumor that turns to be a perineuroma. And there are so many ways to do this. And this is a case where a big lipoma was found by the MRI. Neuralgia paresthetica is probably the most common lower limb entrapment that I encounter. And it's a very frustrating to treat surgically. Luckily enough, 90% of the cases will improve on a conservative treatment. So the lateral femoral cutaneous nerve is formed by L2 and L3 and has an intra-abdominal and pelvic course. Then it exits the abdomen through underneath the inguinal ligament, just 2 centimeters medial to the anterior superior iliac spine. Most of the time, the patient presents with pain that radiates or at the anterolateral aspect of the thigh. An important notice here to remind you that it involves the buttock. So involving the buttock does not necessarily mean it's a radiculopathy. Lateral femoral cutaneous nerve or neuralgia may involve part of the buttock. Now, it's believed that because of the protuberant belly, this will kink the nerve, but 100 different causes has been incriminated. This nerve is very inconsistent anatomically, and it's only present in 60% of the time, which makes the surgical intervention very difficult. And sometimes we don't see the nerve. Pre-op, trying to find the nerve can be difficult, and I basically try to elicit a Tinel or to reproduce the symptoms by just basically squeezing the fat and the fascia over the iliac bone. As we have mentioned, that conservative treatment is successful in 90% of the cases, and that involves the weight loss, avoid white and tight belts, using non-steroidal anti-inflammatory. You can do injections in the clinic, and just be patient on the patients, simply because surgery may not be satisfactory. And I usually cut the nerve and not neuralize it, simply because we have 5 randomized controlled trials and 5 favor neurectomy and 1 only favored neurolysis. So that's what we do. We go in and we cut the nerve, and we follow the nerve very proximal, and we slice the inguinal ligament to make sure that we are not missing branches. This is an example of a very extensive branching. Missing one of those branches may leave a very unhappy patient. Tarsal tunnel syndrome is commonly diagnosed syndrome, yet is a very rare surgical disease. We don't operate on those as much. We get the diagnosis very often, then it proves to be not the case. And the reason is that EMG is very sensitive at the foot, and there are so many false positives, and abnormal electromyography is very common at the foot, simply because these muscles are stressed during our life, and having positive fibrillations or positive sharp waves is not uncommon. It's similar more or less to the carpal tunnel in a way that the medial plantar nerve supplies 3.5 toes, and the lateral plantar supplies 1.5 finger. Now, the differential diagnosis is vast, so I advise you to do these cases with your foot surgeon's colleague, because they can be tricky. And again, always get an MRI or high quality ultrasound with experienced ultrasonographer, because you will be surprised to see things like tumors or synovial cysts. Synovial cysts are not uncommon in these cases. So unless you have a good history of previous ankle trauma or a previous ankle surgery, be careful before making the diagnosis of tarsal tunnel. And again, it's not only dividing the flexor retinaculum will solve the problem. You have to divide you have to release also the branches, and we also remove the septum between the 2 compartments. And very unusual, you will have accessory muscles, and only the foot surgeons are aware of these. These are not my slides, as a courtesy of Dr. Lee Dillon. Now, the conservative treatment can work if you have a good orthotics that can help your patients by giving them a good orthosis. Common peroneal nerve entrapment at the fibular level is an important entrapment, and the entrapment in these cases is at this level. It's not at the popliteal level. It's at the level where the nerve crosses underneath these septi, the septi formed by the tibialis anterior, the palmaris, the peroneus longus, and the extensor digitorum longus. This is where the entrapment is. So when you see those patients again, they will have weakness of the common peroneal muscles, and it's usually incomplete. As I mentioned, the entrapment is not here, the entrapment is here. So it can be very difficult to access the common peroneal and do an effective release from a posterior incision. That's why it's nice and it's easier for us, at least, to make our incision just underneath the head of the fibula, where the nerve crosses the septi that we have mentioned, this position also allows you to release the superficial peroneal nerve if it is needed. These are the facial compartment that we talk about, and this is the common peroneal nerve. We can also check if there is any proximal entrapment using our fingers, or we can lift, but we can lift the wound further. But usually the entrapment is not here; it's usually here. And don't forget, always to image these rare entrapments. Having a synovial cyst is not very, very rare or very unusual, or even tumors. And these are treated in a different way. It's nice to be prepared before you do your surgery, to know what to expect. And it's a nice little pathology where basically we decompress the nerve by incising the synovial cyst. And we also finish this by doing the traditional decompression. I know it's so much to cover in a 45 minutes, but I'll be very, very happy to answer any questions that you have, and even if in the subjects that we didn't address. And please, if you have any further questions, drop me an email. I can send you also the references if you want, and even a copy of my book. Thank you very much. Can you hear me, Amr? خلصت بس
Dr. Addas.
أيوة السلام عليكم. Yes.
أنا صار عندي انقطاع في الاتصال، ما أدري you conclude the lecture, Doctor?
Yes. It's 45 minutes, right? And we're just trying to leave some time for questions.
There is a question from Khalid. What do you think about controversial scratch collapse?
Controversial scratch collapse test, yeah. So this is basically a test that is truly controversial, and either you believe in it or not. And for example, if you are checking for a cubital tunnel and you have involvement of your right side, so what they do, you ask the patient to do this, and you're trying to push their arm inside. So, and you wouldn't get any response. But when you scratch the cubital side, suddenly the affected arm or limb will collapse or will give in. This is not. It's only Dr. Susan McKinnon and few others who believes in it. We don't use it as a helping or a complementary test for entrapments, but that's the principle of it, and whether you believe in it or not, it's up to you. I don't personally use it. And I can see another question: how can I avoid keloid formation in CTS release? That's a good question. So if you avoid the transverse incisions, and if you don't cross the distal rest crease, you minimize the chances of, it's not zero, but you minimize the chances of keloid or hypertrophic scar. So just avoid the transverse incisions or the incision that extend or that crosses the distal rest crease.
There is, I think, Sameh want to ask a question. Sameh?
Go ahead, please.
Sameh? Also, Hisham? Hisham?
Yes. I can see the importance of the peripheral nervous system in the training of the young neurosurgeon. That's a great question. So it is important to understand the anatomy in general, because all what we have mentioned today comes in the differential diagnosis of cervical radiculopathy and lumbar radiculopathy. So even a spine surgeon, or in spine surgery, which most of us will do, it's nice to understand the dermatomes, the myotomal supply, and it's very, very embarrassing to do cervical discectomy when the patient is having a carpal tunnel, or the vice versa, and the same thing of the lower limbs. Besides, it's nice to at least to be aware of the basic treatment of sharp lacerations and the basic ABCs of treating the closed peripheral neuropathy or traumatic peripheral neuropathy. I think it's important just to have a taste of it. I would like to, about the steroids, the role of corticosteroids injection. We know that this is a temporary measure. Patients with CTS and bad CTS who refuses surgery, who, for example, wants to delay surgery till they finish their exams or they have an important commitments. And of course, during pregnancy, it works mostly during pregnancy, where we know very well that after pregnancy, their symptoms will get better. So a temporary use of corticosteroid injection in the tunnel can be very, very rewarding, but it's not, of course, the ultimate treatment. And you have to warn patients that it's a temporary measure.
Any further question? So, we conclude our webinar for today. I would like to thank Dr. Addas for the great presentation and a great contribution to our young neurosurgeon forum. We will be more than happy to have you in the future for more presentation and more participation in our webinar. Thank you very much, everyone. You can find the previous webinars in our website and also in our channel in YouTube. And we hope to see you next month, inshallah, with another webinar presentation. Thank you very much, Doctor.
Thank you very much. Thank you. Pleasure.